We live in a world where there's an infinite need for social services and a finite number of resources available to provide those services, so waiting is an inevitable reality that we must all face at some point, especially in the context of healthcare. Canadian healthcare has become defined by long wait times to see physicians and specialists, to secure diagnostic and surgical dates, and to receive life-saving interventions. In 2018, patients spent on average of 19.8 weeks waiting for medically necessary specialized treatment after a referral from a family physician, a 113% longer wait time than the 9.3-week average documented in 1993. In Canada, wait times for treatment and interventions are often managed using waitlists, which help to appropriately ration and allocate limited resources, such as time and space. This can occur both at a societal level, known as macro-allocation, and on a clinical level, known as micro-allocation. There are multiple advantages to employing waitlists in Canada. Waitlists are intended to provide equal opportunity for all patients to receive care. They also allow patients to make necessary arrangements in preparation for appointment. Waitlists can ensure that healthcare providers and the facilities are not overburdened, and that they are able to review each case in detail. Finally, depending on how they are organized, they help to ensure that patients who have the greatest clinical need are given the highest priority. Despite these benefits, there are multiple disadvantages to employing waitlists in healthcare as well. These include increased time on behalf of healthcare providers to maintain waiting lists, further deterioration of patients' health while waiting for treatment, reduction in patient motivation to seek specialized treatment, financial disadvantages to patients who seek immediate private care, and emotional burdens on healthcare providers and patients who are told that they must wait to obtain treatment. The debate over efficacy of waiting lists is endless, and it is clear that they are not perfect. For this reason, we must work to improve the way the waitlists are managed. This improvement can help to address the central issue concerning the use of waitlists, that is, the potential detrimental effects that they have on the health of patients who require medical care but who cannot immediately access that care. Let's consider the case of Mr. Lambert, a 42-year-old mechanic who hurt his shoulder playing hockey with his children. He sees his family physician, Dr. Simmons, and explains that he is experiencing intense pain in his shoulder, which is preventing him from performing at work. Dr. Simmons refers Mr. Lambert to Dr. White, an orthopedic surgeon whose waiting list is 13 months long. Mr. Lambert is informed that because his condition was not a result of a work-related accident, the next available appointment is in 9 months. While he waits for his appointment, Mr. Lambert is eventually required to stop going to work. Once he sees Dr. White, he learns that an MRI is needed, which has a wait time of 5 months. Mr. Lambert asks Dr. White to recommend a private clinic so that he can get an MRI more quickly, despite paying a large fee. Let's examine this case more carefully. From a utilitarian perspective, waitlists provide the greatest good to the greatest number of people because they provide all patients with equal access to services and opportunities. All people are required to wait to access treatment using the system, making it a fair strategy for allocating resources, thus adhering to the ethical principles of justice. Waitlists can also respond to relevant differences in cases and are often constructed so that those in greatest need are treated first. However, this may be difficult for individuals like Mr. Lambert, who may not be considered a high-priority case. From his perspective, it may feel like he is being neglected rather than being given equal opportunity. This view led him to request private care, which would result in out-of-pocket fees. This is one potential drawback of waitlist systems, where individuals who may not be able to afford private care due to low socioeconomic status and who may have cases just as severe as Mr. Lambert's and cannot access care as quickly. This may also be perceived as an unfair advantage that Mr. Lambert has that allows him to cut in line and be treated more promptly. When evaluating Mr. Lambert's case, it is important to consider the ethical principles of beneficence and non-maleficence. Beneficence is defined as the expectation of healthcare providers to act in the best interest of patients to improve their condition. Non-maleficence is defined as the responsibility of healthcare providers to do no harm to patients. The principle of prioritarianism also plays a significant role in the management of waitlists. Patients who are considered worse off are often given access to care first. Urgency of cases is evaluated in order to ensure equitable distribution of resources. In this case, and in most cases, improving the condition of individuals who are in greater need of care and ensuring there is no harm to their health takes precedence. However, it can be argued that this directly impedes on the principles of beneficence and non-maleficence because it results in a greater deterioration of cases, like Mr. Lambert's, as they wait to receive care. This can have detrimental consequences, such as job loss, and cause more harm to patients like Mr. Lambert by exacerbating their conditions. This case illustrates some of the advantages and disadvantages of using waitlists, but different factors can be considered when examining different cases. Let's visit a different patient. Consider Mrs. Johnson, a patient with end-stage liver disease who requires a liver transplant. She is put on a national waitlist for a liver, but her condition deteriorates and she develops several complications while she waits. These include spontaneous bacterial peritonitis and variceal bleeding. These conditions are treatable, however, her overall health becomes compromised and this affects the success of liver transplantation. She must be treated before she can receive the organ transplant, and her active status on the waitlist is revoked. She must now wait even longer to receive this life-saving procedure. In Mrs. Johnson's case, it is important to note that the health complications resulted from her long wait time to receive a transplant. It is arguable that removing her from the waitlist for something out of her control is a clear violation of the principle of justice. As mentioned, justice is often equated with fairness and ensures that all individuals have access to resources. Justice also responds to relevant differences in cases. Because Mrs. Johnson's case deteriorated so quickly, she deserved higher priority treatment. Unfortunately, she did not receive the treatment she required and therefore was not an adequate response to her needs. Despite this, it can be argued that removing Mrs. Johnson does benefit other individuals on the waitlist who are ready for transplant, making it a just system of resource allocation. It would be unfair to individuals more eligible to receive a transplant to keep Mrs. Johnson on the list, as she requires further treatment prior to the surgery. Although her case is troubling, from a utilitarian perspective, removing her from the waitlist was the best response that could benefit the greatest number of people. Additionally, when considering the ethical principles of beneficence and non-maleficence as defined earlier, it can be seen that Mrs. Johnson's doctor was acting in her best interest. By removing her from the waitlist, Mrs. Johnson's doctor was advocating for her present needs, which outweigh her future concerns. Keeping her on the waitlist and having surgery prior to recovery from her conditions would cause undue risk. Conversely, it can also be argued that Mrs. Johnson should have not been kept on the waitlist so long in the first place. This goes against the principle of beneficence and non-maleficence, as Mrs. Johnson's condition deteriorated substantially during the long wait time. Lastly, let's consider this case from a deontological perspective, which will allow us to evaluate the case based on duties and intentions of those involved. It is clear that Mrs. Johnson's doctor did not intend to do any harm by removing her from the waitlist. As discussed previously, the doctor's intention was to avoid undue risk that would likely result from proceeding with the transplant. However, the duty of the doctor should be also weighed heavily in this case. The doctor should advocate for Mrs. Johnson and has an ethical responsibility to ensure that she receives timely care to prevent any harm that may result from a lack of care. In Mrs. Johnson's case, the doctor's intention and duty to her does not seem to align, and one of the main conflicts of using waitlists in healthcare is illustrated. Looking at the cases presented and the different elements of ethics, we can see that the ethics of using waitlist systems in Canada is complex. Waiting lists affect many lives in both a positive and negative manner. The principles of justice, non-maleficence, and beneficence can be seen in both cases and plays an integral part in assessing the ethics of waitlists. Theories of ethics such as utilitarianism and deontology are also incredibly prevalent in the case studies. All these factors work together to prove that the waitlist system in Canada must change. Regardless of an individual's stance on the necessity of Canadian waitlists, it can be agreed that there is room for improvement. This may be difficult because there are no accepted standards or widely used systems for waitlist structure and management in Canada. It is therefore recommended that the waitlist system be reassessed frequently and guidelines be put in place with clear and precise criteria on how to best manage them to optimize healthcare that is being provided to millions of Canadians. Waitlists have long been a frustrating topic in Canadian healthcare systems, compounded by many patient complaints and negative experiences. Examining the ethics of waitlists seems to offer no instantaneous solution. However, it is a good first step towards bringing more attention to this long-standing Canadian experience and paves the way for positive change.